I have a 27-year-old patient dealing with a reduced level of consciousness, ANO times 3, may have spinal injury, and complains of a ankle injury. Upon examining, there is a deformity at the ankle, requesting assistance. Before we start, we'd like to say that it's Black Friday coming up in a couple hours, days. Whenever this podcast came out, you don't have much time.
It ends. It's going to be done in less than 48 hours.
Yeah. So go check it out on the Rescue Swimmer Mindset podcast, on the rescueswimmermindset.com. We have everything 40% off. It's the only time of year we do it. The brand new lifeguard masterclass by 40 plus year veteran lifeguard 𝐦𝐤𝐥𝐢𝐭𝐞 goes to ocean bathymetry. It goes through making the rescue, how to assess a rescue. It's really our first rescue swimmer course where we are actually truly breaking down like drowning and patients in need and how to attend to them. So that's really cool. Probably our best course yet. Nevertheless, we also, if you're trying to develop your underwater skills, we got the Hold Your Breath Like a Helicopter Rescue Swimmer course, still our top class because it's been around for the longest. Check that one out. 40% off. Perfect form masterclass if you're trying to develop your swimming skills. If you're just trying to train, win the day, that's a top workout course. Check that out. What's that going to be like?
$48.
$48 for, what is it, 4 months of training or something?
4 months.
Yeah, that's better than you get from a trainer. So yeah, check out rescueswimmermindset.com and let's get into saving people.
The rope is free!
What?
The rope is free!
Ah, shit!
Liam's fallen into a crevasse, and I immediately thought he was dead, or at least seriously hurt.
And my guts had been ripped out of my body and were being contained by my flight suit.
I know a mountain lion is on top of me. Welcome to another episode of the WILDERTAINMENT podcast, as well as the Rescue Swimmer podcast. This is one of the few ones that we are combining, so you can see them on both platforms, because today is a topic that is pertinent to both the Rescue Swimmer mindset as well as wilderness, because we are going to be talking about EMT and wilderness first responder basics as far as like how to attend to a patient, how you approach the scene, how you interact with the patient, and pretty much the step-by-step process that all first responders use, whether, again, that be an EMT, a paramedic. It's fairly similar. My background personally is as a rescue swimmer, a helicopter rescue swimmer in the Coast Guard, where we're all nationally registered EMTs. And I've also gone through a wilderness first responder course, which is one of the higher first responder courses you can take, and that implements how you deal with patients in the backcountry. And then I also have some ski patrol background, all of which have really helped. And every time I learn something from all these different certifications and different fields as far as like how to deal with a patient. And I'm here with RSM Cody.
What's up?
You want to talk about your medical background as well?
Pretty similar to Vince. Just I'm a nationally registered EMT, currently working in the Coast Guard as a rescue swimmer. So we basically practice the normal EMT, and hopefully we can kind of combine and kind of mesh together the wilderness EMT with the regular old EMT.
Absolutely. So today, what we're going to try to do is I'm going to be approaching it from more of the wilderness first responder step-by-steps, and then Cody's going to chime in with the EMT standards and maybe how they're slightly different here and there. So let's start with a scenario. So we'll go through the whole step-by-step process, going through this example that we'll be referencing. So in this scenario, actually what we recommend is you go to Knowles. What is it, Cody? Do they have these blogs?
Yeah, it's just a Knowles blog. We can post the link in the show notes or whatever, but it's just Knowles, various blog posts with a lot of like case studies on, it seems like just past situations they had, and they just do a little blog and do EMT notes on it and kind of what went down with all the vitals and stuff. Pretty sweet.
Yeah. So we're going to tweak one of the scenarios that you can go on the website and look at. So this incident is Cody and I, and let's call him Johnny. Johnny's a good name. Let's go with Johnny.
Johnny.
Cody and I and Johnny are on a multi-pitch rock climb. We've been going for about 12 pitches now, and we're running low on food. Johnny is acting a little strange, not exactly communicating as efficiently as he normally is, acting a little, I don't know, arguably drunk. His skin is almost a little like ashen. Not quite ashen, but let's say it looks pale. And it's his lead. And we're like, you sure you got it? And he's like, yeah, I got it. And he's kind of cranky. And he goes up. He's about 6 feet above his last piece. And he falls. Let's say the piece rips out, but then there's another piece like 2 feet there. So his fall, if you know about rock climbing, he's 6 feet above the piece. And therefore, the rope is still going to go 6 feet past the piece. And then the piece ripped. So another 2 feet. We're looking at like at least a 20-foot little fall here. And he impacts his ankle. And so there he is. And he's moaning, groaning about his ankle pain. Did he invert, Cody? Did he invert on his fall?
No. He just kind of landed awkward.
Okay, land awkward.
I'd
Maybe a little
say,
sideways, a little sideways.
Yeah,
and then
okay, sideways.
hit his hip
Yep.
and maybe his side a little bit. All right, that's
Got
our
it.
scenario for Johnny. Great.
Two of us we're at the belay station, right? So he's below us.
Well, no, he's still above us. Maybe.
Oh, he's above us. Okay, I thought he might.
Yeah, he's above us.
Okay,
He's
cool.
above us. Let's not make it too complicated as far
Okay.
as like the logistics of rock climbing and rock climbing rescues.
Yeah.
But yeah.
Yeah. Okay. So if he's above us, first thing you got to do is like with as far as EMTs go, and I'm sure it's like this for wilderness EMTs, you want to like create a scene safety. You know, make sure the scene's safe. Which in this case, you wouldn't necessarily think the scene is safe, right? So,
Well, how is it
it's
safe
not-
for us, right?
we're safe in our belay. We're both like probably anchor, and then have some sort of tether, a secondary tether. We'd want to make him safe by getting him down towards us and anchoring him to where we are to start.
Oh, yeah. So the first step of the multiple step process, and before actually getting into this, because this is literally from now on, we're just going to break it down, what we're going to do step by step. But before we do that, hey, we're not instructors. We are trained in these different certifications, but we're not qualified instructors. So don't take this as like it is slightly subjective. It's going off of our training, but you should fulfill and go through like the proper venues to actually get the training of this. But this is kind of cool because we're giving you a free, more or less, our approach with our training to dealing with a patient.
Yeah.
That said, we don't know what we're talking about.
Yeah, a total disclaimer here. Yeah.
Yeah.
Also, and then if we say something that's totally messed up, you can just reach out to us and tell us what you would have done, and we can even post that and be like, "No, that was stupid. Why would we do that?" Because there's a lot of different ways of approaching a situation like this, you know.
Yeah, or just talk shit on YouTube, you know.
Yeah,
We
you
love
just leave a
that.
comment.
Yeah. Total donkeys. Don't listen to this. Unqualified. Bogus. So yeah, scene size up is kind of the first tier of what we do. And the first part of that is, what are the hazards? What is making me unsafe? The first thing is me. All about me. So I think one of the main things, a lot of times we get super excited. We see something happen, especially if there's like blood or a big trauma. We're like, oh, let's go rush and help. Well, take a second and think, all right, what can hurt me? This person just got hurt. Why could that not potentially happen to me? Now, in this scenario, what could hurt me? Well, all right, maybe there's a rock fall. Maybe this person dislodged a rock. We didn't really talk about that. Aside from that, like, we're secured here. Me, yeah, all about me. I feel kind of safe as far as like the hazards of that goes. As far as woofer goes, we kind of commingle the me with PPE, so personal protective equipment. So typically, if you're dealing with somebody, especially a stranger, honestly anybody, you should at bare minimum wear some surgical gloves. And what they actually recommend is wearing a mask, especially now with communicable diseases. I mean, they've always been around, but there's much worse things than COVID out there that you could spread if you're dealing with a stranger. And then they even sometimes recommend you wear some kind of Gore-Tex to protect yourself. So do the best you can, and then eyeglasses too, if possible. Now, this is Johnny, we're close friends. Don't think he's got any type of diseases. That said, if there's bleeds, it could be great as well for his safety for us to put on some surgical gloves as we attend to him. Anything to say on that, Cody?
Yeah, we're the same thing from the National Registered EMT, just the basic. We call it BSI, bodily substance isolation. So you do BSI, scene safe. So in this scenario, though, typically you probably aren't going to have gloves unless you're like a guide party or something. But you're probably not going to have gloves in the scenario given. But that's pretty standard. Yeah, gloves, face mask, all that stuff. some sort of protection for your skin, like a Gore-Tex would be nice for sure, or just like a long sleeve or something.
Yeah. Well, if you're slightly organized and like squared away, which I often am not, unfortunately, even though I have like all these certifications, but like you should have a very minimal first aid kit, especially if you're doing like something very remote. And we could talk briefly about that, but yeah, I'll just say like gauze would be a good thing. Surgical gloves should be in there. They don't weigh anything, so that doesn't matter. Bandage, some kind of like ace wrap. What else would you put in there, Cody, for
Maybe
like a
some
short
duct
mission?
tape.
Tape for sure.
I think
Yep.
also with the gloves, it's always like, if you're dealing with a patient who has any sort of like substance or blood, sometimes you're gonna need a few pairs of gloves. So don't just pack like one pair of those latex gloves or whatever. Just pack like, they're super light, so maybe pack five pairs or something.
Yep, they rip easily as well, and yeah. All right. The other thing, as far as woofer, so woofer kind of goes through again. We're all here in the scene size up. We've gotten here. We haven't even attended to our patient yet. This is kind of our assessment, right? Or our approaching the scene. So the other thing is environment that we talk about. So maybe just keeping that in mind, like what environment am I on or in? Okay, now we're on a rock face. Is there a storm coming? What time of day is it? Is night coming? Are the temperatures gonna drop? Do we have rain? So these are kind of things, all factors that we're taking into consideration. A, for our safety, and B, for, okay, what's the urgency? Like, what are we going to potentially be dealing with externally? So that's a big woofer thing. So woofer goes through, and that's whole scene size up, we go through hemp. So hazards, first thing we talked about. Environment, which is, what's going on. And then mechanism of injury. And patients is like the last step of this hemp acronym. So running into mechanism of injury, what just happened? So Johnny just took what do we say, 20-foot fall. He impacted his ankle and then he hit his hip. That's a significant fall, and we actually made a very detailed blog post, one of our most in-depth ones on our website. Check it out. We'll put that in the show notes as well. And this runs through so you can read all of this and the breakdown and the flow charts of it. So that's going to help you out visually. Now, that said, as far as describing a mechanism of injury or a significant mechanism of injury, there's certain qualifications, and usually that rolls into play of what are we considering as far as spinal injuries go. It's not that important, but we're keeping that in mind at this point. So significant mechanism of injuries could be getting extracted from a car. That's automatic mechanism injury. I think, what's the height, Cody, of a fall that's a significant mechanism injury? Do you know?
I don't remember. I want to say like 7 or 8 feet. It's not that high.
It's not. I thought it was maybe 12 feet, but
it could be. But yeah, it's always so dependent on surface type and all that stuff. Like it's hard to say. But yeah, there is a textbook answer. I don't know it.
Right. Now, but that said, was that height landing on the feet, or was it landing on the head or on their side? Those are all factors you're taking into consideration when you're considering the mechanism of injury of your patient. So what's the height? Where did they fall? On rocks or on snow? Did they fall standing, or did they fall charging down a bicycle and went over the handlebars? What was their speed? So you're taking that into consideration, and this will mostly come into play as far as what am I thinking as far as their spine, because their spine is fairly important. Not important just yet because we want to deal with the life-threatening injuries as we get into this, but we're keeping all this stuff in mind. And then the last thing is the patient. How many patients are there? Sometimes we'll get distracted and we just see the one. So a couple examples of not taking the time before jumping into things to think about the patients or patient is in ski patrol. I've heard of a case where other people attended to it, but it was a avalanche, and I think 3 individuals got swept, and everyone jumped into the first beacon finding that they found. They dug, and he was I think 10 feet down. And of course, his body was all broken and unresponsive, unconscious, and everyone just worked super hard at resuscitating this one person. Yet, only 10 feet down was another person buried with their hand sticking out of the snow, and their airway was barely obstructed. But yet, instead of just distracting that one person, going to the next potentially, they put all their energy into that one and all their resources. They had multiple people there into that one instead of potentially saving somebody that could have survived, and they unfortunately did not because everyone was focusing on the one patient. And another example of that, Cody, is in rescue swimmer school, literally half of my class in the final test, I would say, failed because they didn't take the time to, I mean, we weren't going through the EMT steps at that point, but they didn't take the time to assess their patients and take a second to look at the scene, do their scene size up, and assess what the situation is and who's the priorities. What they did was they jumped, and I don't want to disclose too much of the secrets of like the last test, but they jumped into somebody that was, a spinal injury and underwater, and I don't know whether or not they were unconscious, instead of attending to others that by just giving them buoyancy and allowing them like that, or just supporting them before going into that like most critical care person. And they failed because like these other people drowned in this scenario rather than them helping them before attending to that other person. So it's important to not get tunnel vision and just jump into the one patient. It's important for us to not get tunnel vision and get sucked into jumping into the hazardous environment. So these are all things, the scene size up, it's making sure things are safe and taking a second to breathe, take a deep breath, maybe even two, and then go and you can deal with your patient. And I think the last section of the whole scene size up is getting consent from the patient. So, hey, I'm an EMT. Hey, I'm a wilderness first responder. Can I help you? I'm medically trained. Would you mind if I lend you some assistance? And you're trying to get consent. If they're minor, technically you're supposed to ask the parent for the consent or legal guardian for the consent. So keep that in mind as well. But then the other thing, as far as still in the scene size up, now we've kind of come to our person. We've introduced ourselves. If there is a major bleeding, so we're talking typically an arterial bleed. An arterial bleed, you can tell it's arterial because it's bright red blood and it's usually squirting or flowing very profusely. Even before you go down your ABCs, which is the next thing we'll talk about, you want to put pressure on that. So if you get to a scene and this person is pouring out blood, that is like the most important thing. And the most critical care thing you can provide to an emergency situation is apply immediate pressure on that bleed, because that will kill them even sometimes more than like their inability to breathe. So, and we're not going to get them out of this situation if they lose too much blood. How much blood is in a body again? Is it an adult human?
Let's see, 5 liters.
5 liters. Okay, so 5 liters of blood in a human being. So we only have so much, and it's nearly impossible to administer it out in the field or in a timely fashion. So you want to keep that blood, that perfusion, which allows the whole body to regulate everything. You need that blood to stay where it is. So we apply pressure, and pressure means you're pushing hard on this one. You're pushing. Like people are always afraid they'll put like their hand on a bleed. No. You put, like, if it's an arterial bleed, you're putting pressure on there. And if it's preferably with some gauze or something clean, preferably, there's going to be infection probably down the road. So the priority is just the pressure. Apply the pressure, and if it keeps bleeding, the approach is apply another piece of dressing on top, more pressure. If that bleeds through, well, now at least for Woofer, and we should talk about it, Cody, as far as EMTs, but from my knowledge of past like several years, tourniquets are applicable again, and how you apply that is you apply it 2 inches preferably above the injury or that main bleed, not on a joint, so like not on the knee, not on the hip flexor, like not on a shoulder, but 2 inches preferably, if possible, above that bleed, and then at least, and then you cinch that down until hopefully that bleeding subsides, and then you could write the time, usually a tourniquet, or try to write the time. That's good to provide to medical, and do not remove that tourniquet until it's done by a doctor or somebody in higher care. So
yeah, pretty standard.
So that was like the scene size up, which I did include dealing with a severe bleed. Anything you guys add as a step?
That's pretty much it. You address all the things. There's just like different as far as like how you split it up with the life threats in like the National Registered EMT course. You do that right after, like in your primary assessment. It's the second step of your primary assessment after you do level of consciousness. But it's kind of I guess you guys didn't. I don't know if I heard you talk about level of consciousness yet. Is that a part of?
Yeah, it kind of is a part of the scene size up, isn't it? So. Okay. In the article I wrote, we actually talk about in that scene size up. So again, HAMP. So again, it's the hazards, what can happen to me, environment, mechanism of injury, patient. But then under that, there's like a little subcategory of push, pull, and prevent. So push is push, and we're talking mostly that arterial bleed, That's kind of what we're talking about. But it's pull a patient out of a situation. So, in skiing, a lot of times people fall in a tree well and they're head down and in the snow. So pull them out of that situation. If they're in the water, if possible, pull them out of that situation, pull them out of that hazard that's like about to happen. Their head's on a train track, pull them off of the train track, So that kind of rolls into the environment too, but like pull them out of the hazardous situation, and then prevent them from drowning, from falling, or being swept farther. So in this situation, like prevent them from falling. We have Johnny on belay here, prevent him from falling further if possible. And then still as well in that assessment is you're kind of getting a general understanding of that level of consciousness, like you just said. So is that person still coherent? Are they unconscious? Are they communicating with us? Are they communicating a little in a drunk manner? And we'll talk about like kind of the more thorough assessment for their consciousness in a second. But yeah, so what level of consciousness are they is usually still in the scene size up.
Cool. Yeah, I think you hit them all.
Great. So I guess let's roll into the ABCs. So the next step, the next bubble, if you will, is the primary assessment. So yeah, Cody, you want to start it off?
Yep. So from the EMT, National Registered EMT perspective, we kind of sliced it up. I was talking about. So we did, are they responsive or not? So level of consciousness, and we do AVPU, alert, verbal, painful, unresponsive. So are they alert? Do they respond to if they're unconscious? Do they respond to verbal stimuli? So if you say, "Hey, can you hear me?" No response. You would move on to painful. Try to touch them. Get them to like get some sort of physical reaction. You can do like just grab their, their trap, or some people do like sternum rub. It just depends on the protocol and what you do based on where you're at. And then unresponsive would just be no response to any of that. And then right after that, we do apparent life threats and chief complaint. So what's their chief complaint? In our case, it's going to be some sort of hip and ankle issue. That's all we know about now. And we know he was also a little drowsy before the fall. And then apparent life threats, probably aren't going to see any major bleeding on him. Maybe you do, but most likely not. It's going to be some sort of broken bone that you're going to be dealing with, maybe internal bleeding, but we're not sure about that yet. And then we're going to move into airway. So that's ABCs. Airway is the first one. Is that how you guys roll? Do you go?
Pretty much. Yeah.
Yeah.
I think I actually like the flow of that in this latest Wilderness First Responder course, and I did that with a outdoor medical. We'll put the link in the show notes as well, but I did that with like a local team here in Squamish. Yeah, they didn't have the chief complaint quite to start, but it makes total sense to just ask that question, and you're not attending to that chief complaint yet. So like their ankle, but you're noting that. So if it's not life threatening, which an ankle, and if it's not bleeding profusely, it's not. You're just taking that as a note. One thing I just want to mention as far as like the level of consciousness Cody's talking about, sternum rub. Yeah, you grab your knuckles, and you kind of just rub it on the person's chest and between like their nipples and their sternum there.
Yep.
And that is usually it's pretty uncomfortable. You can do that pretty strong. But like AVPU is the acronym. So AVPU. A is alert. Are they talking to me? And that's when you kind of do the A and O times 4. So you ask them, usually you can just do this really quickly, and it's kind of like in your patient approach. You go, "Hey, what's your name?" "Hey, Johnny. Couple questions, may seem stupid. You know what just happened?" And he's like, "Yeah, I just fell." In this case, Johnny, let's say he's like a little groggy. He's like, okay. So he didn't really answer like what just happened. He did say his name is Johnny, and we're like, "Johnny, do you know where you are?" And Johnny's like, "Wyoming." And we go, "Do you know what time of day it is?" He's like, "Afternoon." So those are 4 questions, general questions that we tend to ask, and that is usually we'll report that later, but it's A and O times 4, which means alert and aware, right? Is that A and O? Alert and
oriented.
Thank you so much.
Yeah.
Times 3. So like 4 is ideal, but Johnny didn't really know what just happened or didn't communicate that. So we could say he's A and O times 3. So that's the A in the AVPU, and that's pretty good, but he's got a slight altered potential level of consciousness. But then the next step is verbal. So like Cody said, like, "Hey, Johnny," you can snap your hands, and if Johnny, he may only respond with like that would be V on the AVPU. Next step would be pain. So again, with the sternum rub, he didn't respond to either me communicating or me screaming at him or clapping my hands. So if we pinch him and now he's still going like, okay, well, then he responded to pain. So he's like slightly potentially conscious. And then you is unconscious. So there's no response to anything really, pain or anything. So that's like the least ideal of the level of consciousness. So I just wanted to bring that up. But anyway, continuing on. So you were, or were we at the airway of our
Airway.
ABCs at this point? Yeah.
Yeah. So if we're playing out the scenario, I would just yell up to him. He's probably, how far of is he? Maybe he's like 10 feet or something.
Yeah, let's say he's pretty close. Yeah.
Yeah, you're just like talking to him normal then. So you're just saying, "Hey, Johnny, can you hear me?" If he responds, are we going to say he responds in this case?
Yeah, he
Probably,
responded.
yeah, right?
Yeah, like we said, A-no times 3 though. A little
Yeah.
altered.
So we're going to have his airway's clear. So you kind of can just move off from that if your airway's clear. You can skip all that. Do you want to go into the airway stuff or?
Sure.
With airway, basically, if you had an unconscious patient, you would just want to open the airway and assess the breathing, essentially. And then if you want to maintain the airway once it's open, so if the patient wasn't able to have their airway opened like by themselves, you would insert some sort of adjunct, like an OPA or NPA. That's the only part of the airway that the NREMT covers there. And then we go into breathing, and then that kind of has a little bit more.
So me and taking this recent course, they were kind of talking about how often they're leaning away, at least for wilderness first responder, potentially from the OPAs, because it's just hard sometimes to utilize. It's actually, I think more than anything, it's like, are you going to carry that in the field for wilderness first responder, and likely not.
Right.
You can just open the airway. But anyway, as far as like opening an airway, the most efficient and effective way is, say your patient's laying supine, so on their back, you put them on their side, and you literally just tilt with utilizing your hand on your chin and head, you just tilt their head back, and then you can just open their chin. And that's most, like, naturally when you put your head back, your airway is actually opening up. So that's the easiest and most effective way. If you're suspecting a spine injury, which in this case of Johnny, potentially, he took a big fall here, landed a little bit on his side maybe. So say he's unconscious, we would try to do a head tilt jaw thrust. You put your thumbs underneath the jaw. Actually, it's hard to explain when it's on yourself, but then you're going to push it down and open the jaw and trying to keep the head in line. It's hard to do.
Oh yeah,
now
it's not your. Yeah, it's thumbs, and then it's like
opposite.
on the. Yeah. The thumbs are. Yeah, it's the opposite. Sorry, we're being
thumbs are on the chin. Thumbs are on the chin.
It's thumbs on your jaw if you're doing it yourself.
I can't do it because I can't do it myself. But
your thumbs are on the chin, or
and index and
up here.
And what is it? The middle finger are on the
mandible.
The mandible, and you're pushing the jaw forward and then down by pushing that chin down. Quite hard to do. If you can't do that, just tilt the head back, and we'll deal with the spine later. It's more important that you open the airway. That's more important that your patient can breathe. And then if they have something that's obstructing, or if they're going to puke, lay them on their side. As far as getting this airway clear, if there's something in there, you can. It's arguable, but you want to be careful about running your fingers in there. But if it's very shallow, you can maybe grab it and scoop it out of there, or roll them to their side and try to get it out of there. But try to clear that airway. So airway is the first A of ABC, DE in the Wolfert case. Yeah. Breathing.
Cool.
B.
Yeah. And then for the sake of this case, again, breathing, you can't really assess breathing the way you would as like a classic EMT if you had an unconscious patient or something, but you're going to just be kind of looking at how he's breathing. You could visually inspect, see if he's breathing rapidly. By the way he's talking to you, you know if he was breathing super heavy or calm or like sort of lackadaisical, and not like you might have a significant head injury where you might be having some sort of weird breathing. It'd be hard to assess from afar, but you can kind of start figuring it out. And as you lower him towards you, and closer to where you're at, put him into the anchor, you could kind of really get a better view on that. You want to make sure he has adequate ventilation. So typically someone breathing regularly is going to be breathing 12 to 20 breaths per minute. So if he's under that or above that, you're going to be kind of concerned. And then there's thresholds where if it's below 8, then you're going to want to be thinking about some sort of method to ventilate via some sort of device that you have if you had like a bag valve mask or something like that. But for this case, you're not going to have that. So you're just going to be seeing how he's breathing. And in this case, he's probably breathing fine because he just hurt his hip and his ankle. Yep.
General thing with assessing the breathing is look, listen, and feel. So you're looking, if possible, maybe try to expose the chest. Like, hey, can I just see if there's any type of bleeding here? If they're willing, and this is not a medical patient, maybe put your hands on their chest, have to take a deep breath and a deep exhale, and seeing if that's struggling, if there's any types of weird sounds, so wheezing, like, or it's just labored, it just doesn't sound right. That's pretty much all you're checking on the breathing. Now, in the instance that they're not breathing, now you're kind of rolling into the CPR, and you want to administer 2 rescue breaths. And a rescue breath, again, should be done with that open airway. So tilt the head back, open that, make sure the jaw is open, and administer those 2 breaths, and preferably with a mask. I wouldn't put my mouth on like somebody I don't know. Yeah. So then next step is C. ABC is C is circulation. What do we got, Cody?
Circulation is, you're going to be checking the pulse, see how their pulse is. Generally, if you're just a active or just a regular person, it's going to be 60 to 100 when you're resting. So you're going to want to, if their pulse is super slow, you're going to suspect some sort of injury, probably some sort of head injury. And then if it's super fast, that's actually probably going to be anticipated for a situation like this, because they're going to be a little freaked out. They were already exerting themselves, so you'd probably expect it to be above 100 at least, probably like 110 to 140. Pulse, assess the skin, so you want to look at their skin. Are they flushed? Are they pale? Does their skin have like any weird hue or color to it? That's more of like a perfusion thing, see how the blood's circulating and all that stuff.
And you do that by lifting their shirt and putting your palm on their belly, and that it should be pink.
Yeah.
Like pink looking.
Yeah.
Pink, warm and dry is ideal, right? And then
normal. Yeah. And then
if it's cold, cool, and clammy, and if it looks pale, then that's not good.
You're just looking for abnormalities and just something that looks out of the norm. And then so we already kind of did the major bleeding assessment. We did the tourniquet and assess for life threats, but you do it again here, and then you start some sort of shock management. So you're going to be, if they're cold, or like some sort of, if they're bleeding out, you want to put a blanket on them and all that stuff and try to get them warm. That's not really going to be ideal. Like, we're not going to do that in this situation. Maybe you have an extra jacket you can give them if you're not too cold, because you got to consider your safety as well. But you're just going to be trying to think of ways to get them comfortable.
Now, that is a huge important factor, especially for wilderness first responders, keeping that patient cold if it's a cold setting. Of course, if he's dealing with like a heat stroke, then you're trying to get him out of that element. But generally, if you're dealing with any type of like trauma or something, you want to keep that patient warm, because them thermal regulating is not going to be as efficient in this instant. So you want to keep them warm, because it could induce shock. So really, that should be a super important priority, as soon as possible. Getting out of the snow, or at least lay a tarp down or something, or put them on some skis or a snowboard, or I don't know. So in this instance, I don't know. I'm guessing, let's say it's like fall, so it gets cold at night. So we got to keep that into consideration and keep this person warm now. That said, talking about like major bleeding, do you guys for EMTs, like, did we classify that in the circulation? Because I feel like still major bleeding should be a priority even before, like, now they say like that's the priority even before you go into the airway, right? Do you guys categorize it under circulation?
It's in there. Maybe I don't have like the most updated one, but it's in there. But we also do the life threats / major bleeding at the start. So I think it's just like a backup, just to make sure you're not forgetting that.
Right.
If I had to guess, I'm not sure their intent or whatever, but it's in there.
Usually circulation, I think, from my recollection, is you're doing a blood sweep. So, how we would do that is we would literally put your hands, especially like underneath the patient, because you should be seeing something on the front, but underneath the patient, kind of just run your hand underneath the arms, underneath the back, and pulling your hands out and seeing if there's blood on your gloves. And you're doing that all through, like down their legs, under their butt, and then you're just making sure that there's no blood, something that you're missing. And note that if they're wearing anything like a dry suit, like rescue swimmers, if they're wearing Gore-Tex, the blood could be underneath that. So take that into consideration in that assessment. Maybe I wouldn't be cutting stuff if you're out in the elements per se, but at least ask your patient if they're verbal. Do you feel wet anywhere? Do you feel like maybe you're bleeding somewhere? And if you do suspect something, then you should expose it, whether that's cutting or lifting clothes to check it out. And then I guess we should talk about, okay, so say the first thing you said in circulation, check for pulse. There's no pulse, not in Johnny's case, but like say there's no pulse.
Yeah.
This is when you roll into your CPR. So you've done everything that we talked about, but now you're rolling the CPR. You're giving them 2 rescue breaths, and then let's briefly talk about CPR. The training is 30 compressions, and that is again done on the sternum. So generally look like between both nipples. You're putting all your weight over your two palms, and then you're administering the compressions, and that's between 100 and 120 pumps, if you will, per minute. And yeah, that usually goes, it's pretty quick. Why don't I do a little, generally speaking, I think it goes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. I'm going to go to 30. So then going to 30, and then and then when I hit 30, I'm going to either, in this case, say Johnny's unconscious. Hey, Cody, can you administer the breath? So Cody opens the airway, head tilt, jaw thrust, or maybe we suspect a spine. So if he can, keep the neck immobile, but he's opening the airway and he's administering 2 breaths. And you're looking for a chest to rise and fall. If it's not, then you're not really doing anything, right? Because there's probably something that's clogging that airway. So make sure you're trying to look as you're administering those breaths, and then going right back to CPR. And then CPR, the other part of it is usually you do it for 2 minutes, but like during this time, hopefully you ask somebody, is there an AED around? So defibrillator. And if there is, somebody's getting that, and then you're administering those pads. And that's like, I mean, I'm not going to go through that because any AED is, I think they've like tested it. I think like 6-year-olds can figure out how to use that, really, because it's literally
like tells
the
you how to do it.
biggest little drawings on it. So you put the things on the chest and cross, and then you plug it in, and it literally tells you what you need to do. But you keep doing CPR, and CPR you don't stop until you're at higher care. Because technically we're not doctors, we can't really call it. So once you start CPR, technically you're not supposed to stop until you do. But hey, if I'm in backcountry, I'm not going to do it for like 10 hours.
Yeah, it's very case dependent.
Yeah. I remember a chief when I was in Hawaii, when I was stationed there as an airman, had a case, and he started CPR on somebody that was clearly already dead. They decided it wasn't worth the risk to hoist this person because they were unconscious, but he started doing CPR, and he did it the whole way back to port, and that was like, I believe, 2 hours, and he was just on his knees alone, the family looking at him as he's like doing CPR for 2 hours. His like knees were bloody to the bone. I think he like ripped through like the wetsuit, and like even the wetsuit has pads on it, but like it still ripped through, and like and just like kept doing it. And he was like, he almost stopped, but he was like, it just doesn't feel right to like tell the family, A, you're not supposed to as like a first responder, and then B, like he didn't feel right like stopping with the family being there, being like, oh, we're done, so anyway, all right. So then for woofer, there's like D. Do you guys go down like the D as well? A, B, C, D, E?
We might. It just depends on what is it. It just might be called something else.
So D is like disability, is as far as like this latest course I did.
Okay.
So for that, you're kind of doing the more thorough, the level of cautiousness you should have done, as we talked about before. But you're also assessing like the spinal restriction. So you keep that into consideration. This is where you're like, okay, I've treated the main issue, as in like the airway, the breathing, the circulation. Now, should I have somebody maintain spinal restriction? And spinal restriction is just pretty much the best you can do is keeping the spine in line, and having somebody or some objects keep the head of the patient and the neck in line with the thoracic and the rest of the spine. So in that D, disability, you'd think, okay, does this person have a potential spinal injury? In this instance, say we get Johnny lowered back down to a ledge, I think that would be a good idea for us to be like, hey, Johnny, can you just try to, like, if it's comfortable for you, can you try to lay down and not move your neck and too much? And Cody, you mind like manning the head and just kind of making sure Johnny doesn't move his head too much. I did want to talk about one thing I learned in this recent course is a lot of new studies that come up as far as first responders go. It's really proven at this point that the spinal injuries happen on impact. It happens in the moment of the trauma, right? It's very rarely made more severe or worsened by post-trauma movement of the spine. It's very rarely like a medical professional that happens to move the patient or too abruptly or something that causes more damage. It almost never really happens. So keep that in mind. That said, medically and like certification wise, we're still trained to maintain that spine. Is very important. It is important, but just know that it's like, you know, if you need to move this person, that because something is like potentially life-threatening, do that. Prioritize that, I would say, honestly, then rather than like freaking out about the fact that the head needs to be like maintained and everything, you know, and make sure those priorities are attended to. But that said, yeah, if possible, in that D, disability, spinal restriction, make an assessment on that and get somebody to hopefully make this person's spine a little more stable. And then the last one for woofer is exposure. So ABCDE, exposure. So yeah, expose their like chief complaint and treat any major injuries. So like, yeah, say it's like a compound fracture and you have like the tibia sticking out. Okay, well, honestly, actually, if it's not bleeding severely, like you could just expose it, make sure it's not bleeding severely, and that's okay. Just like, but just expose it, make sure it's not an arterial bleed that was like underneath some Gore-Tex or something that you missed. Yeah, check out their chief complaint, expose it. They talk about exposure to the environment, so but we already talked about that in the circulation, which I actually prefer that it's there, dealing with shock and keeping that person warm. So yeah, exposure to the environment is like keeping them warm, and if it's a heat emergency, keeping out of the cold environment. Note that if you're dealing with a temperature issue, so like hypothermic or heat stroke, heat exhaustion, you don't want to like, so for heat exhaustion, you don't want to throw somebody in an ice bath. And if somebody is hypothermic, you don't want to put them in a hot tub or in like a sauna. You don't want to like do that drastic change in temperature. Many things could go wrong in doing so. So try to just keep them warm in a slower pace, but you know, yeah, put them in a sleeping bag if they're cold. But yeah, one thing they've talked about is like people have been like unconscious, almost pronounced dead, and then they've heated them up. They heat them up like a degree, I think, every day or something. So it's like these hypothermic people, you know, there's that whole saying of like they're not dead until warm and dead. So especially for these hypothermic patients, they heat up the patient like 1 degree every day or something, and then like, you know, over a week or two, and then this person like comes back with no brain injuries or no, like they're good as new. Keep that in mind, and especially when you're doing like CPR or dealing with unconscious patient, if they're cold, work hard, you know, because that person still has a shot. So yeah, all right, so now we're done with ABC, and in the case of woofer, DE. So again, airway, breathing, circulation, a disability, so the spine, and then exposure, just exposing themselves to the environment and exposing the injuries. So all right, next step, Cody. Yeah, what is it for EMT?
Next up, you just start doing it's called history taking with the trauma. So it's vitals. You just get their vitals. So basic set of vitals is blood pressure, pulse, respirations, and then you can do like a SpO2 or just their oxygen saturation if you have the ability to do that, and then some sort of sample history.
Well, before we get into that, I want to say like for us, and I kind of like this, especially like in people that are doing all these like remote things and like in a case like this, before we roll into even the vitals, I like this step, and it's in the, you know, the blog that we wrote up. It's make an assessment. So ABCDE, now make an assessment. Are they stable or unstable? If they're stable, then we can roll into what Cody just talked about. If
That's
they're
true.
unstable,
Yeah, I also kind of left it out. Is you want to make sure like you just decide like their priority of transport, basically. So do you want to treat them now, stay in play, or like try to get them somewhere safe? So yeah, I think I just skipped over that. Totally forgot it. But yeah.
So in the case of Johnny, let's say we've gotten to Johnny. We've assessed, we've exposed his leg. We notice that the bone is displaced. There's no bleeding. But Johnny's still, he looks kind of cold, cool, and clammy. That's a warning. We don't like that. Yeah, he just looks flush, and he's not communicating to us very well. So, well, that's a little worrisome, because now we're really noticing that he's not exactly coherent. So he's not exactly like the most conscious and like the most there. So we're a little worried. If those resources available, I would take that into consideration. Now, maybe we're in a remote place, but if we're not too far, then maybe we can make a call, because we're a little worried based on his skin color. There's no major bleeding, but like there's something going on here. Maybe it's internal bleeding. We haven't seen anything. There's no deformities on the chest when we check that out. And so far we've done our ABCs, nothing crazy abnormal here, but yeah, he's not exactly the most conscious. So I'm a little worried, but that's the thing. So you're making an assessment of whether this person's stable or unstable. He's kind of in a gray area right now. But Unstable could be major loss of blood. That's certainly something that's unstable. An obstructed airway, trouble breathing, cardiac arrest, signs of shock, and like a decreased level of consciousness, which Johnny is a little bit. So yeah, I'd say if possible, maybe we make a call. Yeah, I'm like, Cody, can you try to call EMS or search and rescue? Basically, you just have to call 911 if you don't know what to call, and maybe report back what we found, that this person has a decreased level of consciousness, ANO times 3, and we're not looking good for his skin color, and these are our findings so far.
And yeah, for the sake of this case that we're doing right now, so you said we're like 12 pages up, right?
No, well, at this point we got him to our level, right?
Yeah, but we're still up on a mountain.
Sure. Yeah.
Right. So yeah, if you're communicating with ground control or whoever, we'd probably be doing that on saving on cell phone service, like a Garmin or something. Like, let's just go through what we would do here. Like, so we've done all our ABCs and all our initial stuff. What was our determination? Are we going to wait for a helicopter to come get this guy, or are we going to lower him and try to get out of the hazardous scenario? Because this is, we don't have to necessarily do it yet, because we can move into our next like secondary assessment and all that stuff. But we kind of want to be thinking about what we're going to do,
Yeah, and like in this scenario, it's like take consideration of, okay, like how far are we from search and rescue? And this actually happens in your scene size up. When you first get there, is like, okay, where are we? Are we very remote? How far are we from care? So like, yeah, if we're like in a situation where it's likely going to take 3 hours for like search and rescue to come to us, maybe it's just might as well roll in a secondary assessment, because like how much more time is that going to take before we call it in? That said, and so in this case, maybe I would do that, roll into that secondary assessment, and we're going to talk about that. But it would not be wrong to make the call now and get people rolling, and you can always call them off. That's also a great approach.
Yeah.
So call it in and be like, hey, I have a 27-year-old patient dealing with a reduced level of consciousness, ANO times 3, may have a spinal injury, and complains of a ankle injury. Upon examining, there is a deformity at the ankle. Yeah, and that's it. Like we haven't even taken our vitals yet, so we can't really report that. So requesting assistance, and we'll call back, or maybe even keep them on the line if possible after a secondary assessment. Now, that wouldn't be wrong. So yeah, so calling for that help. But how about we roll in a secondary assessment at this point?
Cool. Yeah, secondary assessment. I always thought it was like super lengthy. You got to do it all. But for a conscious patient, it might be a little faster, But basically, you're just working your way. For a trauma secondary assessment, you're just focusing on finding any like injuries that you might have not thought about in the initial primary assessment. Because the primary assessment, you're treating ABCs, airway, breathing, circulation, and then you're kind of treating the major, like there might be major bleeding or some sort of bone sticking out. You're treating all that. All right, so when we start the secondary assessment, we're basically going through trying to find things that we missed in the primary assessment, and basically you start head to toe. So from the head, all you're doing is getting, with PPE, you're putting hands on. So you're going to start back of the skull here, and you're just going to palpate, looking for any deformities. Where they teach DCAP, BTLS, so deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. But basically, just checking for anything abnormal. You're going to do the back of the neck.
The stupid thing too to keep in mind is things that should be squishy should feel squishy, and things that should feel hard should feel hard. So the skull should feel hard. So when you palpate means press, and you can apply some pressure. Don't be weird about it. And like it's, if like this patient is like totally fine, maybe like if this is a medical injury, somebody's just sitting there, maybe don't go and squeeze their head. But like
you do a different
but in this instance, you're feeling around the head, you are applying some pressure and asking them, does this hurt? Does this feel strange to you? Does this create any kind of pain? Or go ahead.
So you're doing that side of the head, and you're kind of working towards the face. Do the same thing at the face, and then you're checking the airway again, make sure there's nothing lodged up in there that you missed. Checking the nose, make sure like the nose, you could have broken nose, some sort of like breathing issue with that. Then you check the eyes. So eyes, you're going to be looking to make sure they're reactive, and looking, so it's pearl, pupils equal, round, and reactive to light, equal in size. So you're checking to make sure that both of the pupils are the same size, and one's not way big and the other one's tiny. Round, you just want to make sure they're shaped normal and not shaped irregularly. Just if they look like normal eyes, they're good. And then reactive to light, you're shining. If you have a light, some sort of light, you're going to be shining that kind of in the eye and making sure both eyes react. So when you shine a light in to an eye, the eye's going to get smaller, right? So the pupil is going to get smaller, and you want to make sure that they're getting smaller. And then when you remove the light, it's going to get a little bigger, so it's going to dilate slightly.
If you don't have a light, just have them close their eyes for maybe 2 seconds or 3, and then have them open them and try to look at both and how they're opening and adapting to that light, the pupil. So, yep.
Perfect. Yeah, yeah. You might not have a flashlight. Headlamp could work, but yeah, that's probably the easiest way is just have them close their eyes.
The other thing to look at is raccooning around the eyes. This could be a sign of concussions, but they always often teach that in EMT school. Likely that's not going to happen within like the half hour of that injury. That usually comes like 3 hours plus after the incident. But
Right.
if you do attend to somebody later on, then that could be a great sign of a brain injury or a head trauma. So you're looking for raccooning. That means like kind of darker around the eyes. Ears, if there's bleeding coming out of the ears or if there's fluid, mostly fluid is a sign of brain trauma. Good example though is like, don't freak out, because like, yeah, as a ski patrol, I remember once attending to a person and other ski patrollers brought him down because there was bleeding in the ear, but it turned out it was just his headphone earbud that was in there, and it just cut the ear. So like, if you can actually inspect, it would be fluid coming out, not per se blood. It could be blood, but if it's blood, maybe see if it's a laceration, but keep that in mind.
Nice. Yeah. So yeah, check the ears. Moving on to neck. So with neck, it's like there's a few things to check in. So position of trachea, you're making sure there's not like some sort of distortion. Basically, you're just trying to make sure it looks like a normal neck. There's no like distortions or weird bleeding that you didn't notice. And then you want to palpate. This is the NREMT, so palpate the cervical spine. So you're just checking to make sure that it's super light palpation, that there's no like some sort of huge bulge somewhere in the spine that would indicate a spinal injury. Is that standard with null or wilderness EMT?
Yeah, I mean, at this point, still in the secondary assessment, I think at this point we're just feeling. So yeah, same thing. Yeah, looking for any bulge, deformities. Yeah. Oh, I want to talk about, which is kind of unique to wilderness first responder. I forget the exact name, but doing a further assessment of the spine to see, because if you're in a wilderness setting, sometimes it's just not reasonable to maintain the spine just because we have a mechanism of injury that's significant, versus like EMT. Sometimes we just err on the side of caution, we get them out. We assume there could be a spinal injury, but there's a secondary or like a further assessment of the spine that I want to talk about.
Got it.
Wilderness first responders too, but it's not here yet. So let's keep going.
Yeah, we'll skip on it. Yeah, so neck, you move on to chest. So when you do the chest, you want to expose the chest, actually look at it. Maybe you have to cut some sort of fabric, might just be able to lift up someone's shirt, and you're going to palpate the chest, looking for, a lot of times you could be like a flail chest, a lung injury where one lung's working, one lung isn't. You might be able to see that when they're breathing. By looking at the chest, you're going to check for like some sort of rib, and like a broken rib or something like that. Make sure they're breathing normally again. And then you can do, at this point, actually, if you have a stethoscope, you can check their breathing and listen to their lungs. And that's pretty much all for chest.
Yeah, but you can assess like the 4 quadrant, and I know you mostly do that for the stomach, but you can still do that for the chest. Apply some pressure, have them take a deep inhale, exhale, assess all 4 quadrant, feel, and you might see if the ribs are broken, then they're going to be operating at a different, like as they take an inhale, it's going to be going in where those ribs are broken, and then it tends to be opposite, and then and we won't talk about like filler chest and all that nonsense, but like
there's a lot of stuff for the sake of this, not so much. Then you move on to abdomen. So abdomen, you're just, like you said, there's 4 quadrants to your abdomen that everyone teaches. So you're just palpating. It's basically just split the stomach up into 4 areas, and you're just palpating each area and checking for, I think you check for like rigidity or pain. Basically, you're wanting to see if there's like areas that feel hard that shouldn't be hard. Generally, I mean, nothing should really feel hard in there unless you're like a little lower towards the pelvis. You'll feel the bone there, but everything is going to be sort of soft, and you don't want to feel like any sort of hardness or stiffness somewhere, because that's going to generally indicate internal bleeding or some sort of significant injury.
It should be
squishy.
Squishy.
All squishy. Yeah.
Squishy.
And that's pretty standard squishiness. And then you move on pelvis. So you're just,
I do want to say though, if you do find something in the abdomen, that's something you want to be worried about. You want to, because you don't know what the hell is going on there, and that could be very not good. So if something feels hard, if you see discoloration there, if they're even complaining of pain, women, that could be many different factors, but I'd say that's somebody you want to get the hell out of there.
Yeah, that would kind of turn into an immediate transport and whatever you could do. Like if you're like contemplating, lowering, rappelling with them, you might want to just get like a faster team in there. If that might not be, it depends on a lot of
depends on the case, but
response time and all that. But yeah, for sure, you're going to be elevated level of awareness for that for sure.
But I'll say this, like if you're calling in SAR or whatever, people to get somebody out of there, I'd venture to say that most people will not judge you for making that call, because you never know. Like, patient could look super stable, complaining of like a stomach pain or abdominal pain, and then all of a sudden they drop, and you're like, shit, and then they die.
And it could be too late.
Yeah. Totally. So it's not a bad call if you're worried to just call that in and then try to get a quick evacuation.
Yeah. So then you're moving on to pelvis. You basically put hands on the pelvis, and you're just kind of squeezing in and up, and you're making sure there's no weird movement. Is it called? It's crepitus. Like if there's some sort of fractured pelvis, you'd feel it basically like a cracking and kind of like a abnormal movement there. You don't really feel any movement, so that's the big thing for that.
And that's also a big one, right? Like, so that's pelvis if there is pain there, and because there could be internal just a pelvic fracture, that's something that we're also very worried about. So that's it's arguably critical. So
also for the sake of this, we're kind of getting like into the depths of the secondary assessment here. So we're doing this on our actual patient right now. He's at us, and so we get to the pelvis. We're feeling the pelvis. We know he hit his hip, and then it feels fine. Or does he have a pelvis injury? If I feel it, what am I feeling?
I don't know. Do we want to make this case
no.
urgent? Okay, so then no.
I think it's too complicated.
Yeah. But let's just say briefly, say he is, and like there's significant pain there, and maybe even we feel crepitus. What we could do as an option with this is, try to improvise, and we don't have a pelvic, what is this? Pelvic splinter, whatever. The thing that cinches down, we don't have that, but what we do have is his harness. So that's something you do with a pelvic fracture, and it's not a bad thing. You're never going to mess it up by applying that pressure. So it could be something good to do, but you could maybe use the harness, but put some padding around so we kind of have a larger volume or larger point of contact on that, and then applying the traction, and it's just below the hip bones, the pelvic bones. So
this is the iliad crest. I think that's what it's called.
Yeah. So basically, you just go underneath that that bone, and it might be all right. But so you're cinching down, and so that we could use this harness to maybe do that. Honestly, that could be something if that were the case. But let's say there's a bruise, but
it's fine.
It's fine. Yeah. So moving on.
It's good to hear. So that's fine. You move on. Then you just move on to extremities. So you're doing, since you're already at the pelvis, you can just go straight to the legs. So when you do the legs, you're kind of offsetting your hands, and feeling on the way down. Basically, you're feeling for any broken bones or anything. So any abnormalities, as you feel, you're gonna feel all the way down the femur, down to the lower leg, and then onto the feet. And when you do the feet, you're just feeling same thing, just palpating. A lot of times, you'd want to take their shoes off. And this would kind of, for our case here, I forget if we said left or right leg, but whatever leg I'm on, say I get to the injured ankle, you're going to want to really inspect it and kind of but you're probably at this point just going to see a lot of bruising, not even bruising. You're going to see inflammation, right? Like a lot of swelling, maybe not even that. It might just be too soon. But he'll have a pain response to you putting hands on there. So it'll be pretty obvious. And then you're going to check the pulse down there basically, and their motor skills. So find the pulse. I forget what it's called, but it's kind of behind the pedal pulse. Yeah. You're just checking to make sure there's a pulse down there. And then function. So, hey, can you push on my hand? Put your hand on the bottom of their foot. Try to push and then pull, and then see if they have sensory motion senses on their toes. So hey, what toe am I touching? Pick a toe, and then see if they're sensing that you're touching the right toe. So big toe right there. Yeah, that's pretty much it. And then you repeat.
If you're watching on YouTube, this is foot porn, but yeah, basically, if you want to check the pedal pulse, there's two ways. One is right here. Let's see if I feel it. Oh yeah, found it right away.
Wait, you gotta go higher. Oh, wrong camera. No, sorry, I'm looking at.
Oh yeah.
I'm looking at the wrong camera.
Yeah. So I feel it there, and then the other option is hit right there. Let's see if I find it though. This is good to practice. I didn't find it just out.
It's hard to find. Those
I
are
found
hard
it.
pulses.
Yeah.
The pedal's the easiest, and then I forget what that one's called. The one you're doing on the back of the ankle
I forgot to. Yeah.
Yeah.
This is I'd say that, I don't know, that one's, I often find it is easier to find. But it is, some people just have less perfusion there, so you could be freaking out like, oh my god, they don't have circulation in their extremities. But like if you check them regularly as well, I wouldn't find it. So these are good things to practice. And when we were even talking about like in the circulation phase all the way back up to ABC, checking the carotid pulse, it's right here, right? But it's hard to find. Like you gotta practice.
Yeah.
And then the brachial pulse, right here on YouTube, is it's on the inside of the wrist towards the thumb, like between your.
That's your radius. That's your radius.
That's the radius on there. Yeah,
Yeah.
on the inside.
The radius is close to the thumb. Yeah.
Okay, radius.
And the almost
So
on the outside.
in between the radius and kind of the center line of your forearm, there is where you get your pulse there on the brachial. So good things to practice, like not in an emergency. So 'cause, yeah, it's always like, it seems cool in a movie or something. You see it, you're like, oh yeah, just check the neck. But then you get to the scene and you actually try to check the neck. You're like, I'm not finding it. They're dead. But like maybe you just suck at taking.
Also,
it. Like,
and like check other people's pulses, not just yours, because it's easy to find. You get used to finding yours, but like just like check your friend's pulse or something, because it's harder to, it's kind of mirror it, and it's a little harder when you're dealing with someone else. So, yeah.
But anyway, so the feet, you talked about checking the circulation. So on both feet, you're doing that. And then you talked about mobility. So yeah, push, pull. So like, can you pull on my feet? And you're doing this with both, hopefully at the same time. Maybe, maybe Johnny doesn't want to do this because he's got an ankle injury, and that's fine. But you're pulling on the foot and you're trying to see the strength. And like, that's okay if it's an ankle injury. Like if he's willing to try that, because then we can assess that. And push as well. That's same thing. And seeing which is stronger, which is weaker. And cap refill on the toes as well. We can do that. So if you want to pull a sock off, if it's appropriate to do that, apply pressure to the nail. Screw it, I'll do it again on TV. Yeah, you push, and then within 2 seconds, that blood should come back to that.
Yeah,
nail.
it goes white. 2 seconds.
White,
Back.
But you see it like literally in my this woofer research. I applied a tourniquet to somebody because they had it was like an arterial bleed, and so I applied it like around like the humerus area on their arm, and I didn't apply it too strong because it's just a scenario. But as I was doing my secondary assessment and stuff, I got to doing this mobility test on the hands, which we'll talk about in a second. It's the same thing as the legs, but squeeze my fingers, right? And then I like checked the cap refill. I didn't even need to. I could just check on his skin, and it would take like 5 seconds. And we're like, oh, do you want us to loosen that tourniquet? Because like it's not looking great. It's looking cyanotic, so your hand is starting to look blue. So like that's something to keep in mind, right? And you can see that too, as far as like the skin color on the foot. If you're exposing the feet, like is it white? Is it getting bluish? Well, then maybe something's cut off, and that's and in this case, maybe something is cut off. So we'll talk about like our treatment, which is we're not quite at that phase, but like something we're worried about, we can try to realign and put that ankle back into the position and in line with the leg if the patient's comfortable with doing that. So yeah. So anyway, and then I guess I'll just wrap it up for the head to toe. Last thing is the arms, right? Same thing as the feet, but the legs. So you're running down, trying to see if there's any type of breaks there, and then have them squeeze both hands. So like your fingers like this, and then checking the cap refill. So squeezing the nail, seeing if the blood gets back, and then checking the pulse on the brachial pulses there. And that's about that, right? For the head to toe.
Yep. Yeah. And you're doing the same thing with the arms too. So we can just kind of gloss over that, I guess, because it's the same thing.
Yeah.
Right.
Well, that's what I was just saying. So.
Oh, I kind of missed that. I didn't realize you skipped. Yeah. Okay. Cool. So arms, and then so that's that side, and you just move on to the back. So back and butt basically. So you're just checking when you do that. If the patient's laying down, but in this case they're not, you can just kind of like either have whoever's behind them check it, or just kind of have them turn a little bit. But you're just checking. Same thing. You're palpating, checking for any abnormalities. You can listen to breath sounds again from the back there if you have the ability to do that, and then you're just checking to make sure there's no injuries on the back or butt. So that's pretty much it for that. Anything else?
This could actually be a great point for me to roll into like that further the spinal like motion restriction. So whether or not you're going to maintain that or not. This is just, if you're rolling this patient over or just accessing their back. So what you're doing is you're running your fingers and you apply significant pressure all along the spine on both sides. And you got to apply a decent amount of pressure, and that could feel uncomfortable to anybody, but it would be quite an acute pain if it really was a spinal injury, likely at least. So applying that pressure, and if they're like, like that fucking hurts, well then that could be a spinal injury, and we got to maintain that spine, right? But if not, hold on, actually I'm gonna start from scratch. Kind of the criteria before. So the whole point of this little thing is we're gonna assess the spine to potentially, in this Wolfer setting, potentially let go of like maintaining the spine. And that doesn't mean there is no spinal injury. It just means we've assessed enough where we're like, we've reduced our chances of a spinal injury, and we're not too worried about it getting more severe by, again, like letting the patient move. So first thing is your patient alert and oriented and able to communicate, or are they drunk? Are they acting a little strange? So like in this case, Johnny's not exactly, he's a little incoherent, right? Or he's a little strange. So that's worth considering. He's not intoxicated, but he's acting a little strange. And then, is there any major distracting injuries? Johnny's complaining of his ankle, but he's not like, my ankle, and only talking about the ankle, and like it's so much pain that he's like can't feel when I'm palpating this back and pressing on the back, right? So if those criteria are not met, so he's not intoxicated, he's not super distracted by an incredibly painful alternate injury, and he's communicative and conscious, then we can roll into this, and that goes to assessing the spine. So pressure, and then assessing all those the CSMs, which is like everything that we just talked about as far as the hands and feet. So is there circulation to his hands and the feet? If not, if they're cut off, well then maybe there's a spinal injury there. The flow is not it's not responding. And if he can't move or squeeze his hands or push his feet, well maybe there's something there that's on the spine. But if he can and do all these things, and there's no like severe pelvic injury or anything like that, then based on those findings, it may be okay to rule it out. So in Johnny's case, like it's again a slight gray area. Maybe we keep it just for a little longer because he's like slightly incoherent. He couldn't tell us what happened, and maybe he's still acting a little drunk acting, even though he's not intoxicated. So let's keep that in mind. And maybe we'll keep the spine, but if he passes all those tests, then we can pretty much release the spine and be like, yeah, Johnny's probably good. But for now, let's just we're less prone to suspect a spinal injury based on that, because there wasn't pain. His extremities were moving. Maybe he's having a little hard time with the ankle, which makes sense because he injured his ankle. But yeah, so maybe at this point we're like, all right, we'll keep him a little stable, but maybe we're a little less worried about the spine. Yeah, great. So then we did our head to toe. We've done this like spinal as we check the back. I guess the next step, at least for Wolfer, is the vitals, like the more dedicated vitals. Like now you're actually going through and taking like the level of consciousness again, his temperature. So like if you don't have thermometer, you're checking the belly, if respiration. So a great way that I learned actually in ski patrol is like just have the patient like hold their arm here, and like you can in 30 seconds you can get his breath rate or his respiratory rate. So how many breaths per minute, should be between 12 and 20. And you could also get his pulse. So you're holding him here and you put your hand on his back, because you don't want to be like, can you take some deep breaths? Because they're not going to breathe as normally as they would, right? But like if you're just checking their pulse while sneakily assessing their breath, then you're going to get the actual what they're actually breathing right now. So that's a little cool trick. You can just put your hand on the back of their chest, or check the pulse and then put your hand on the back of their chest, and just assess both at the same time. And then you don't need to check a pulse for a full minute to get the heart rate. You can just check it for 15 seconds, multiply by 4, right? So if it's 15, then they got a pulse of 60, right? So and then you can check their blood pressure if you have that, but you might not in the field. And oxygen saturation, well, yeah, if you don't have that, then you can if you don't have a pulse oxygen, you can just squeeze and pinch the nails again, kind of assess like that. So that's the vital signs, and you want to write that down because you'll probably forget. And your whole point with vital signs is to assess how they evolve, right? That's the point of vital signs. It's like, okay, is it bad now, and is it getting worse, or is it getting better? Yeah. And now I think we're rolling into like, as far as Wooford calls it, like the ongoing assessment, but like also this is where we're gonna do a treatment, right? So I guess we can roll into that.
Yeah, treatment. Yeah.
So before we do, sorry, we didn't finish. We didn't do it. It's good to run through our sample, right? So we didn't do that. We can't skip that, and that's why we have this whole step-by-step process. Is like, yeah, you don't want to skip steps. So before we're going to a treatment, it's good to run through a sample, even if it's not a medical patient, right? So I know you started talking about that, but sample is symptoms, allergies. It's an acronym, right? So symptoms, allergies, medication, past medical history, last oral intakes, and then the last one is event. But like, so let's break down the symptoms, and that goes with the acronym OPQRST. Most people use, and Wooford uses it too. So these are great questions to ask. So like to understand kind of the symptoms. So like in this case, with Johnny so OPQRST onset, what happened? So I mean, we saw what happened. So Johnny maybe doesn't need to tell us that, but he's like, hey, why don't you answer, Cody, as if you were Johnny,
Okay.
and I'll just ask the question. So again, we're in the sample under symptoms, and we go through this acronym of OPQRST. So onset, what happened? What just happened, Johnny?
I was like climbing freaking, and my hand slipped and I fell, like, and then it looked like my cam popped, and then I hit the wall super hard.
And now, like, what, are you in pain or?
Yeah, my leg hurts pretty
Okay.
bad.
Okay. Does anything make it better or worse? So now we're in the P, provocation it's called. And does anything make it better or worse is pretty much the question. So yeah, does anything make it better or worse?
Not really. It's just kind of staying the pain. It wasn't super painful, but now it hurts a little more.
Okay. In this position, does it feel good or bad? Because it looks like your foot's a little to the right. Would you feel comfortable if we put it in line? Do you think that would feel better?
We could try.
Okay. So like,
I'm not sure.
Yeah, that's
Yeah.
a question you can ask, right? So
Yeah.
then Q of the OPQRST is quality. So could you describe the pain? Like, what does it feel like, Johnny?
It's like a pretty like achy and like slightly sharp pain, and it kind of radiates to my leg.
That's great. So that actually that rolls into the next part, which is radiation. So like, does it radiate, or does the pain go anywhere else? Like, that's like an answer from like a first responder, like,
Yeah.
but like, it radiates to my leg. Okay, oh, does it? So like, so
Yeah.
anyway, so now, but that's a sign. So that's the next question you want to ask. Like, does the pain distribute anywhere else? Do you feel anywhere
Yeah.
else? That's a great one. But as far as going back to the quality, yeah, you're looking for adjectives. So like sharp, hot, burning, dull, throbbing, right? These are things that you want to maybe note and write down and keep in mind. And then, on a scale of 1 to 10, or 0 to 10, 0 being no pain and 10 the worst pain imaginable, like, how does it feel?
7.
Okay, so noted. And then did this pain like start immediately, or did it just start now? Like, did it hurt
just
the
started
most on impact?
On the impact, and then it started getting worse after you guys.
Oh, so it's getting worse.
It's getting a little worse, yeah.
Okay, so that's all things worthy of noting in the time. So OPQRST, onset, provocation, Q, quality, R, radiation. So where does it go to? And T, time. And then so now we're back in our sample. So that was the symptoms. Let's ask now about allergies. Not really pertinent to this, but it's something that we'd want to keep in mind. Allergies would mostly come into play as far as like anaphylactic shock. So like, is he having trouble breathing, or is there some kind of like rashing or something going on with their skin? It's not really a pertinent question to ask in this scenario, but it's good to note if we're passing him on to further care. So it's always good to note. So like, hey, just for further care, Johnny, you got any allergies?
No.
Okay, great. Then are you on it? Again, this is mostly for further care, Johnny, but are you on? So now we're rolling into medication. Are you on any medication?
I'm not on any medication or anything.
Okay, should you be on any medication?
I used to take sometimes I take insulin.
Interesting.
Yeah.
Okay. Did you take insulin today? Did you need to take insulin today?
I just thought I could skip it since we were going climbing earlier. I just decided to take it when I got back.
Oh, interesting. And if you skip it like this, and like, do you think we did a lot of energy consuming activity today that like may be triggering your diabetes? Like, are you feeling a little low energy? What if you ate this chocolate bar? Do you think that would be a good thing?
Probably. I'm hungry.
Okay. Well, so all right, why don't you have the last chocolate bar, Johnny? And like if that's something that might help, yeah. So like and with somebody that's diabetic and diabetes, I mean, there's literally doctors that are experts at just that. Maybe if you want to talk about it briefly, Cody, but as far as like type 1, type 2, but yeah, it doesn't hurt regardless if it's type 1 or type 2 to give that person, if you're suspecting and you don't know what's going on. More than anything, the patient's going to know probably more about their diabetes than you do if they're conscious, so they can communicate what they need. But nevertheless, if you're worried and you think it's something like, and if they're unconscious, then you can apply some hopefully it's usually a paste or some kind of sugar on their lip. You don't want them to choke on it. But if they're conscious, it's not the worst thing to give them, regardless of their type of diabetes, a little sugar. You want to talk about like diabetes a little bit, Cody, or like?
I mean, I think we actually probably don't need to get into it really. Just give them. You can just, when you go through like the sample, you kind of brought that up with, like, if you didn't do the sample, you would have kind of missed the part where the person's having like some sort of diabetic emergency where they need glucose. Basically, like when you get to that point, they're drowsy or have like some sort of low cognitive, just like a lower cognitive output than normal. You just give them some sugar and see if that helps. But that's about all you could do from our perspective, as and getting them to a higher level of care. So that's all you really need to cover for that. But there's a lot of like little details with diabetes and stuff that I don't really want to get into, just for the sake of treating someone in a situation like this.
That said, okay, so now we just gave Johnny a little sugar here, a chocolate bar. So we'll assess and see if he's doing any better. As we're, because eventually we're gonna redo our set of vitals and we're gonna reassess our level of consciousness. So hopefully Johnny maybe is more communicative. But let's keep rolling down our sample. So we've done our symptoms, our allergies, our medication, and we found out that Johnny may or may not. He usually takes insulin. He is not today. Was going to. Hopefully we shouldn't give Johnny medication, but we can ask and see if he should be taking that, and if so, maybe encourage him to do so if that's proven to have good results for him. So anyway, past medical history. Yeah. So do you have any prior surgeries that are relevant to this ankle, Johnny, that we should keep in mind?
Pretty healthy.
Okay.
I was like,
okay.
I never had a broken bone.
As far as like diabetes goes, so this is like past medical history. Like, have you had these reactions where you're a little groggy, a little like?
Yeah, it's happened a couple times in my life.
Okay, great. And like with that glucose, does that tend to get better?
Yeah.
Great. All right. So hopefully, again, we'll reassess that. So that was the L last, that was the P, past medical history. Now let's go to L, last oral intake. So yeah, Johnny, when's the last time you ate?
Just had like some oatmeal in the morning before I was climbing when we woke up.
Okay. As far as like your diabetes go, is that potentially not enough for how much activity we did today? 12 pitches?
I usually eat a little more. I probably should have brought snacks or something, but I haven't eaten as much as normal.
Great. So, okay. So this is all telling us like maybe Johnny was definitely reactive because of his diabetes here and like acting drunk. And like this is worrisome a little bit, or like, but hopefully he's going to do better as we keep reassessing here. But great. What about your last like pees and poops? Anything abnormal there?
No.
Okay, great. I think that's it, right, for the last oral intake?
Yeah.
Last food. Yeah. You didn't eat anything that was like abnormal for you, really?
No.
In the last little bit? Okay, great. And then the last thing is events. So anything you were doing like leading up to this that that we should like keep in mind? Like anything, did you do any like crazy activity yesterday where you might be?
No, we're just climbing yesterday, so
okay, so
pretty normal.
A little more exertion. So anything else you'd consider, Cody, as far as like the event stage of sample goes?
No, I don't think so. I mean, it just depends. Maybe you could uncover kind of, you're saying like they were doing something like the day before, like they ran a marathon or something, and they would be like depleted on their glycogen sort of stuff. But you already covered that.
Great. So yeah, so that's the sample. It's super important. So yeah, if we would have skipped that, which I kind of did actually, right? Yeah, if we would have skipped that, then we might not have discovered this patient, that Johnny is diabetic, and hopefully Johnny would have actually communicated that to us going outdoors
Yeah,
and
you'd want to know
multi-pitching
that.
with us. But maybe he didn't, and because maybe he's embarrassed. I don't know. So these are things that are it's all clues to the puzzle of trying to discover. You're just really, in a lot of these cases, you're just trying to like discover the most information you can, and there's only so much you can do, but try to unveil as much information as you can, and sometimes you're just like a little detective trying to figure out what's going on here. But now we've done our scene size up. When we got there, everything was safe. We went through all that, and we did our ABCs, our primary assessment, which is like any life-threatening things. We went through our secondary assessment now, which included that head to toe, that included our vitals, and that included this medical history, which is the sample that we just ran through. And now we go through like our ongoing assessment, so we can reassess vitals, but in this instance, we'd probably treat Johnny, and that would come in the form of for the ankle, Johnny, can we apply, so for most joint injuries, if it doesn't cause too much pain, can we realign and try to apply a little bit of traction and realign that ankle? And if Johnny, because a lot of times that will alleviate the pain, applying a little bit of traction there. So just pulling that, and maybe Cody's maintaining that, while I would, this is not a compound fracture, there's no bleeding there. So I would probably apply some kind of like ACE bandage and wrap. And how I would do that is, again, I'll bring out my foot porn over here. So you can wrap the ankle, and you can do this with tape, but I'd probably do an ACE bandage first. You wrap an anchor around the ankle, so like that, you just call that the anchor, and then you would wrap going under the foot and going to the exterior. So your wrap should go here, and then likely, if comfortable for your patient, always be communicating, keeping in line like that. So you don't want to wrap it and like put the ankle inward. You want to be pulling it outward if possible, and then wrapping in the back around the anchor, and then just crisscross applesauce it. And that's pretty much that for the ankle. And then once you've done that, you want to just recheck your pedal pulse, because anytime you administer anything, any type of traction, you want to make sure you're not cutting off the circulation. So recheck that pulse, check the cap refill. So like squeeze the toenail, and then see if the movement if there's still movement, if there was, and then ask Johnny how that feels, and maybe Johnny's like, it feels more stable. Like, thank you. So at this point, we've now treated our patient, and now we'll do a second set of vitals, and say our vitals are now a little bit better. His pulse has lowered, his respiratory rate has decreased. Maybe it was 24 because of that, those diabetic symptoms. And then and then Johnny is now, we've asked him 4 questions like, who are you, where are you, all this, and he's just the way he's communicating, he's definitely 𝐴NO times 4 now. So now, if we did call that further care, we could maybe call it off, right? Like, how would you feel, Cody, at this point?
Yeah, I mean, at that point, yeah, you wouldn't necessarily need, his level of consciousness is getting better with some sort of food, and then at that point, his ankle's stable. You're just worried about getting him off in a timely manner, and you can do that, if you know how to get down. He's going to actually be able to rappel probably, because he's got a good level of consciousness. So it's probably going to be a pretty casual scenario.
Yep.
Versus if he went unconscious and all that. So yeah, I would just call it off and then start getting down.
And as far as the spinal injury goes, we shouldn't ever say like rule in or out a spinal injury, because we're not in a hospital setting. We can never actually make that assessment. But now that he's 𝐴NO times 4 and conscious and communicating, well, I think it's okay for us to assume that maybe a spinal injury is not going to be further aggravated with movement. So, so it's okay to like reduce. So like if Cody was still, or if we were having him be stable, we can like, hey, try to move, maybe move your neck a little bit. Does that feel wrong? Does that feel okay? And if not, if there's no spinal injury or anything, or on his extremities, then he's probably gonna be fine. We can help him out and maybe hike him out if it's not too far or something.
Yeah.
Yeah,
that's a big difference between just regular EMT and then your the wilderness type EMT is just I guess they put in that sort of C-spine, ruling out the C-spine because you're doing prolonged care for longer than an EMT. An EMT would just be transporting, dropping them off, and then they would just be off their conscious. But for you guys, it's about dealing with the patient for a long period of time. So you'd want to rule out a C-spine and not have to deal with that if you don't need to.
Absolutely.
So, yeah. That's cool.
And we didn't really talk about cervical collars, but in the EMT field, when you do suspect a spinal injury, typically you often put in a spinal collar. But often, or actually, recent research, at medical conferences, they're talking about the cervical collar. They're kind of, it seems like they're doing a little away with it, and that's not always the best thing. But yeah. So, but anyway, for now, it's important to try to keep the neck safe, and if you're in a wilderness setting, maybe you can wrap a puffy around just to kind of stabilize the head. So and then backboarding is not also the best thing to put a patient on, because now they have these what is it, vac mats? Do you have those in the Coast Guard now?
We don't have those, no, but I've heard of them. Yeah,
they're sick. It's a deflated beanbag, or kind of inflated beanbag chair, or not chair, but backboard. It's soft, so you just unfold it. It's got all these straps, and you put this patient in it, and then you close them up, put all the straps on, same as the litter in the rescue swimmer litter. Put them in there, and then you pump it, and it becomes super stiff, and it takes out the air and compresses the bag and becomes super rigid, but it also conforms to their back, unlike a backboard, which is very uncomfortable. And when you set a patient up on a backboard, you often want to pad so underneath their lumbar area, and make some padding under the knees, but it's just very uncomfortable. You're on a backboard. You ever lay on a piece of plywood, that sucks.
Yeah.
It doesn't feel good on your back if you have a back injury. So these things are cool. Yeah, man, that was a condensed,
I know, kind of condensed, but also
lengthy,
thorough.
Yeah, you guys just got a free EMT / wilderness first responder course. No, that's not.
No,
the
not
case.
at all.
You should take the course. We didn't even go through the thousands and bajillion ways of treating a patient as well, and we probably missed something here and there. So
yeah. Also, the whole point of if taking EMT class, if you take it, I guess the big outcome for me, I've taken 2 EMT classes now throughout the years, and I think you really all they give you is a framework, and then you use that framework to actually work with patients and try to help them. So yeah, you're not going to learn how to save anyone's life necessarily, but you learn the building blocks to do that. And then hopefully with training and stuff, you can do that eventually. Yeah.
And one thing to always keep in mind is use your patient as your best ally. Ask them questions. They might know more about their body than you ever will. So, how are they feeling? They're going to know what is probably best for them. So ask questions, and don't be it's my way or the highway. I'm the medical professional. Even if you're not, especially if you're not a medical professional, just ask them questions and see how you can just help them in the best way possible with your training that you've had. So yeah. Well, that was a good little condensed podcast. I'm exhausted. Hopefully you guys
good stuff.
Captured a quarter of that, and I think hopefully you can help somebody in the future. At least remember that it is important to have the general steps in your head when you go to a patient, and remember to take a deep breath before you jump into that, to try to remember everything that you're going to go through with this patient. Because if you just jump in head first, which we're always super excited when there's a trauma or something, we're going to forget things. So,
yeah.
All right. Anything else?
Nope.
That's slow down, basically. We do that too, working in the Coast Guard. You're flying a helicopter to a sketchy situation. The last thing you want to do is be speeding towards a dangerous situation without thinking about what you're going to do. So you want to have a plan and all that. And this is the plan, just following whatever framework you have. So if you're EMT, you have your EMT framework. Wilderness first responder, you have your framework, all that stuff. So it's all just slowing things down and having something to work on or work through. But
Great.
Yeah, that's all I got. Nothing else.
And then this Black Friday. Black Friday is coming up on Friday. You only have whenever this podcast release a certain amount of hours, almost maybe, or maybe a day.
Maybe a day.
Maybe a day to order our courses. This is the only time we put them on sale. 40% off all courses, and that includes the brand new Lifeguard Masterclass with 𝐦𝐢𝐥𝐢𝐿, which is one of our best courses now. I would say this guy's got 40 plus years of lifeguarding experience, and it really shows. And we worked our butt off on like the editing and putting this course together. You checked it out, Cody. I'm proud of the course.
It's legit. Coolest. I think it's the best one it is the best one we've done as far as production goes, and just knowledge. Like he started in the 60s, you know, so he has 50 something years of lifeguard or 40 something years of lifeguard experience. So it's pretty sweet. It's super condensed in like a 10, is it 10 chapters on the actual membership page. So a lot of information. They're all super long, super informative. There's a little Q&A at the end. And then if you take the course and you have questions, you can just reach out to us or Ed. Like all the information's in there.
And this is the first course with actual rescue techniques, because we've liability wise tried to mostly avoid that as far as like rescue swimmer stuff goes, though we always include some like secret tidbits in our courses. But this one really breaks down like the rescue process and making the rescue, but also assessing a rescue, assessing drowning individuals. So we go through like all these case studies. We got all these awesome videos that Ed's got like secret access to of like these drowning patients.
Yeah, he just
I'd never seen
accumulated
before.
These videos. Yeah, they're cool because there's actual drowning victims in the surf, and he's just talking about how he would deal with it and how he dealt with it in some scenarios.
Well, the other thing was ocean science. I love that chapter as far as like the wave assessment, swells, what's the word I always forget as far as like the reef bottom?
Bathymetry.
Yes, the bathymetry.
Yeah.
Love that.
The shape of the bottom.
Yeah,
the surface.
Yeah, love that. So
The
that's
ground.
like an awesome part of a chapter. And all of our other courses, the perfect form if you want to master your freestyle and your underwater form and all your egg beater.
Yeah,
Okay.
the lifeguard masterclass. It's not just, I guess I was just trying to cover on who would be the ideal person to take the course. It's not just for people who are lifeguards or want to become lifeguards. You can take it as if you're in the military and you work in some sort of water related environment. So rescue swimmers, like I've gotten a ton out of the course. So Navy rescue swimmers as well. If you work on boats around the water, like all that stuff is going to be good to know because he talks about the way the water works around rocks and all that stuff and how to deal with survivors in certain situations. So basically, if you work around the water, you're going to want to get some of these lessons from Ed.
Yeah. So anyway, all these courses, rescueswimmermindset.com, and a couple more hours or days to go check them out for Black Friday. And as far as everything we talked about as first responder and this patient assessment, wrote up I'm gonna say bitchin' blog. It's on our website under the blog section. And it's probably our most comprehensive piece so far. Free. You just go through this whole patient assessment. It's much more visual than we just described it. So it has like the chart that breaks down this whole step-by-step process. So go check it out. rescueswimmermindset.com. And thanks for listening to the WILDERTAINMENT Mindset Podcast. Yeah. We're out.